Hello and welcome to Ladies Corner with Tea. It's been a minute, hasn't it? Thank you so much for joining us. And happy International Women's Day. If you're just tuning in, it's International Women's Day here in Alberta, across the world, actually. And we have a special guest, Dr. Florence Akindele. She's our guest tonight. And let me just give you a short background. Dr. Florence Akindele has 30 years of experience as a doctor and 20 years as an obstetrician gynecologist. She also holds a master's degree in public health and she has worked in various aspects of women's health in Nigeria, Swaziland, South Africa, now Alberta. Earlier today, she launched or they dedicated or they opened a new clinic, and she's here to tell us Florence Women's Clinic in St. Paul's, Alberta, and she's here to tell us a little bit more about it. Good evening, Dr. Akindele. What a day! What a day! What a glorious day it's been for you.
Thank you. Good evening. It's such a pleasure to be here. Yes, I forget my tiredness when I'm happy.
Yes, and congratulations. Why was there a need to build a home? You called it earlier today at the launch. Why was it necessary to have a Florence Women's Clinic?
So let me start by saying it's Florence Maternity Home. That's what we called it. And there was that need because over the years, so I've worked now in Alberta for just getting to 14 years in the same hospital. And I've seen women ask for home delivery, ask for things, experiences outside the hospital because the hospital is tailored for safety, not so much of comfort. And when women give birth, they want the experience. They want to have experiences they can savor. So the hospital is getting too little in terms of options for women. They keep asking, can't midwives come? Can I bring my doula? And that was the whole idea. So it's to get a home outside of hospital setting. So this home is not a clinic, it's not a hospital, it's not a center, it's a home, is what we call it. I call it my home, inviting women who are able or who live in this environment who want that as an option to come in and have their babies outside of hospital. And we made sure it's about 50 meters from the hospital because deliveries can go not as predicted sometimes. And so you want that safety network where if anything were to happen within 2 minutes, 5 minutes, 10 minutes, you are there in the hospital and interventions can be given to save the situation if needed. Although over 90% of women will deliver normally, the 10% that may have issues would need to have interventions as soon as possible. So that's the whole idea, is to say you can have a whole different experience outside of hospital birthing.
Dr. Akindele, what I find really curious is we're in the West and things are a lot better in the West than in maybe a place like Nigeria, but there is a global decline in childbirth. And in your presentation, you alluded to the fact that the government was not looking to put money into antenatal, prenatal care, or is it what's the word?
The obstetrics, just generally about childbirthing or pregnancy. Yes. So it's been noted. I mean, this is research all over the world. There's a decline in the number of babies born to each woman, and for even the number of women wanting to have babies at all. It's been linked to economics in terms of, limit the number of children you have so that you can have the money to take care of them. But ultimately, what is happening is we're having less babies. Currently in Canada, we have 1 baby per 100 people. That is so much a far cry from replacing yourself. I mean, we have industries, we have workplaces that need young people to fill them up. And post-COVID, it has hit home really badly. Shortages everywhere. There are not enough people to fill them up. So the older generation are getting older. They need the younger to take care of them. Unfortunately, there are not enough younger people to take care of the number of older people that are around. This is what we call the aging population syndrome. And so, yeah, it's a global phenomenon. I was talking with someone today and she was telling me, no, in developing countries, Nigeria, it looks like they're still having too many babies. I'm like, no, you're focusing too much on a locality. If you want to look at global trends, even in Nigeria, women tend to go to school, delay pregnancy. In those days, it used to be age 16, 18, they've started having babies. But now people want to go to school, be economically stable before they do that, which is great. But if it's not done with that, the macro picture in mind, it tends to mean that a woman that could have four chose to have one or two. And ultimately, we are not replacing ourselves in the society. This is research. It has shown a very big impact on socioeconomic issues all over the world, particularly the developed countries. So a lot of developed countries, they have birth rates less than 2, which means each couple are not even producing 2. They're not replacing themselves. So who's going to fill up? And many, one of the conferences or seminars that I attended recently in St. Paul, where I work, the convener, the guy was saying that, look, people love to have dogs and cats more than babies now. And unfortunately, we outlive cats and dogs. They don't have the same lifespan. It's not like having children who would then take care of you later. So it was interesting. He was the one that raised that topic again in my mind. And I said, okay, let's talk about it because it's real and research shows. If you Google it right now, you'll find that global birth rates are declining all over.
So across the province, they released the budget, was it last week, and they're saying they're putting billions of dollars into healthcare in Alberta. Does none of that go into gynecology and obstetrics?
The way it works is not like they will break it down into those kind of bits and pieces. But from my own short stay, I will call it in Canada and where I work presently, I don't see maternal health as a priority. Actually, when I came, I started with a question. I found out that women had to pay for prenatal classes. Um, and I was a little bit concerned. I'm like, why do they have to pay for prenatal classes? I was told, oh, if you don't make them pay, they won't come. I'm like, that sounds odd. I mean, I see smoking cessation classes free. I see alcohol cessation classes free. I see a lot of things around mental health issues free. You can come in, but then to have a baby, you have to pay to be taught. So I don't know that it's about not having enough resources. I think it's a matter of priority and it's a matter of the way things are, the culture of the health system. And I'm hoping that with the shortages and the frequent closures of obstetric services, not even only rural Alberta, it's actually a big problem. Some urban places are also suffering that there's just no obstetrician, nobody willing to work that hard. I think the lives of obstetricians and midwives and people who support birthing in themselves is tedious enough. So to not get encouragement makes it easy for people to say, you know what, I don't want to do this anymore. So it's really a crisis right now. And I'm hoping that the budget will help because I know that previously, Alberta Health Services, many rural obstetric services were closed if they don't have 100 babies per year or something like that. Was a figure. I don't even remember that much now, but it was almost like they just closed it. And so the women in that community will still want to have babies, but they go through hell. They travel kilometers, hundreds of kilometers to get the kind of services they want outside their homes. Plus, they have to pay out of pocket for all those extra expenses. So I am hoping that this comes as part of the priority with the new budget. That's my hope.
Okay, I hear what you're saying. So, how do women? Is it by referral? Is it private health care at the home you launched today? How does it work in practice?
In practice, it's my home, and I'm an obstetrician gynecologist. We're really, really working hard to have midwives come into the community. I love to team up with midwives because they are so much more skilled in going to people's homes or doing the home delivery. And then we have in the community lactation consultants. We have birth trauma specialists, people who can help you debrief and get out of any eventualities that may have happened during birthing. So we all come together, and any of us that are the professionals are able to bring in our clients to come and see the home and work with them, because we can't have all women come. So the numbers that we can accommodate part-time are limited. Currently, it is not funded by government, it's out of pocket. So we know that the numbers of women that can afford it may not be as much also. Plus, if there's a high-risk pregnancy, what we are doing in this home is to say, when we take you up as a professional, we help you look at the risk. And if you are insisting you want to deliver in a home, we can offer to say, you know what, deliver in the hospital for safety. And after the delivery, you can come to the home and we can pamper you through it. We want to focus more on the postpartum, the after delivery care, which many women don't get. Because after the delivery in the hospitals, women are just sent home. In fact, some women are sent home 6 hours after because the beds are all taken and another person is in labor. But we want to focus on the healing part of it afterwards. And that is in a bid to prevent postpartum depression, which many women suffer because, and it could be prevented, at least in some cases. So the way we're updating our website, we will be out there, florencewomen'shealth.ca is going to be updated. And if anyone wants to have a look, we're going to put a picture, the virtual tour on it, so that you have an idea of how it feels in the inside. I know many people were itching to see pictures of the inside. I posted a little bit, maybe 2 on Facebook the other day, and I got such a big response. So we're trying to do the 360 virtual tour, and we will put it on the website for anyone who wants to see. But if anyone wants to deliver there, it's not like a public institution where you can come in labor or you just come in. We need to have known you. It's a home. It's my home. I call it my home. I need you to understand the principles of working with me in the home before you come in. And so that's how it goes.
Okay, thank you. So we've addressed it is private healthcare. You pay for it from out of pocket. You need a relationship to work with you, and that you are focusing on postpartum care. And I know when you've had the baby, the first problem that arises is the baby latching on. Is
Exactly.
milk pumping out? The
Yeah.
baby's not latching.
Yeah, and all that. So we have
Some
a
sort of.
lactation consultant
Hmm.
who would even love to meet you, not only after delivery, but even before. She has an outfit in town, and she does that. The other thing I need to say is any woman, an Alberta woman who delivers in Alberta, we don't collect a fee for the delivery. It is the use of the home that we are collecting a fee from. The Alberta government pays any professional, doctor or midwife who does delivery, who takes delivery, irrespective of the place where the delivery takes place, the government will pay. But the maintenance of the home is what is being paid for out of pocket at the moment. We're looking at, if we can get grants and stuff. We're actually doing research to see how best we can help, particularly women who are vulnerable, the First Nation indigenous population who've been gone through trauma in the past, and we're all doing trauma-informed care in the hospitals. So we want to bring that on and see if we can, have means of helping them financially if they need to. I've also seen another group of vulnerable women, new immigrants, who come in and they don't have health care yet, and they're so scared to go to the hospital, and so they only go in labor. They just appear there and deliver the baby and then run away again. All this, we are trying to see how we can help with that. So at least to start with, what we're dealing with are people who we know, who before they go into labor, who would explain how it works to them.
Okay, so my next question is why St. Paul? I know St. Paul is a warm, loving rural community in Alberta. I wonder what the population is in St. Paul. I was just wondering why not Sherwood Park Why not to Terreliga or Windermere or even Avestilles where I live? Okay, why St.
Yes,
Mhm.
yes. So it's St. Paul because St. Paul is my home. This is the starting point. I believe with time, when women see the benefits, when even the government, when hospitals see that there's a way you can do delivery where you can actually separate and make it cheaper and more comfortable for women than have them deliver in ambulances while they are being transferred out of their communities. Um, then more people then it may be a thing of maybe um, we will take it out of St. Paul. I think it started in St. Paul because this is where I work. I have the privilege to do cesarean sections, assisted deliveries, normal deliveries in the hospital. I've done close to 2,000 babies in this hospital. So I'm used to this place. I want a place where if there's any issue at all, we can quickly shift over and there won't be a problem of we're looking for a doctor or we want to quickly connect with who is there, who may not want to be part of it and all that. So that's why it's St. Paul. And I believe that after it has taken grounds in St. Paul, we can fly.
Amen. You're also a woman of faith, and I like the way you're projecting. You won't necessarily stay in St. Paul. The home will gather momentum and possibly even go national. It's possible that it will change the direction of provincial planning, national planning around childcare. Today is International Women's Day. How significant is it for you that you're launching your maternal home, Florence? It's a
Maternity home. Yeah.
Florence
Florence
Maternity
Maternity
Home
Home.
on
Yeah.
a day like today. How significant is that for you, ma?
It was, we deliberately chose this day, March 8th, International Women's Day, because, for me, women are supposed to be appreciated, pampered. When you have a baby, it's a physiological thing. It's something that everybody should be happy to receive. The community should rejoice. You should not have to worry about communicable diseases in the hospital and all sort of things that have gone on through COVID. I saw the heartache of what women went through to have babies, and I said, no, I'm going to step up and do whatever it is I need to do to get this going. And so we really worked hard to make it International Women's Day so that my colleagues from all over the world, actually, we have a ladies group from my graduating class in medical school. They were all there cheering me. It was International Women's Day. It was easy to connect with people on social media and say something is happening. We are trying to improve the lot of women in this small rural community. We're hoping to reach out to even much more people out there who would have new ideas about birthing that is both safe and comfortable. I know that the world had been in a world of extremes where it's natural birth and then no interventions and sometimes women die, sometimes babies die. We don't want that. We want that midpoint where safety and comfort can come together and give it as a present to women on their day, the International Women's Day. So yes, it was a deliberate pick.
Awesome. And childbirth for me was very traumatic. And I look at my daughter 13 years later and say, thank God I went through this. But when I think about the trauma, it's not something personally I want to experience again. And I
Again.
can understand why in the West, why women are saying no to childbirth, or why the numbers are low, or why maybe even cesarean section is maybe popular. But I want to turn your attention to the other side in non-Western countries like perhaps Nigeria, female mortality, the contrast. How bad is it well, let's start with Nigeria, in countries outside of the West, Western Hemisphere?
Okay, so that's one of my heartaches because I'm Nigerian, born and trained in Nigeria, and I grew up as a medical school. Even in the medical school, in residency, it was a big problem. Women dying from childbirth is still one of the highest in the world, unfortunately. So we look at Canada. We have about 10 in 100,000 live birth, less than 10 actually. I think it's 8 point something if I want to be more specific. uh and so even if you say 10 per 100,000 live births in Nigeria, we're talking of almost 1,000 per 100,000 live birth. That is multiplied by 100 of what goes on in Canada. I mean, training in Nigeria has watched women die from anything from there's just no blood, or this woman has been abandoned by her family and she has no antibiotics. And I mean, I don't know. I don't, sometimes I look back and I'm like, I don't get enough sleep just thinking, how can I make a difference? So, yeah, it's really bad. The US has found that there is a higher maternal mortality ratio than Canada. The US, but it's more common amongst the Black women in the US. And so it's a whole lot of complex issues. When we talk healthcare, we're not talking about simple things. Sometimes 1 + 1 does not equal 2. And to solve problems, we have to break it down into simple parts. So that's why for me, I've learned to take just what I can handle. I will say, okay, if I do this, I think it will make a difference. And I'm not even asking for help. I do it first. And then I say, okay, can you see it's working? Can we make it bigger? That's my own philosophy. And so that's it's still a heartache for me to think of what's happening in Nigeria currently. Actually, sub-Saharan Africa. But Nigeria in particular, the map I was showing today showed Nigeria as one of the worst. Compared to some war-torn countries like Afghanistan, they have the same kind of rates, like close to 1,000.
Would you say it's because there's not enough medical facilities, or there's just a rampant nonchalant attitude by resident medical professionals? I know they value money over life in some instances. Is this a problem in Nigeria? What is the key problem? Do you know?
The problem in Nigeria is multi-layered. It's from the primary to the tertiary. First, of course, there's not enough medical facilities, not enough resources. And if you look at even doctors that work in private hospital, where people will be like, oh, they're about money. Truth is, there's no way to run these systems without money. And we have a general attitude. I remember those days back in the days, a woman would plead with you. They plead with people in the private hospital. I don't have money. And they will go home. Just pass by their house during the naming ceremony. You would wonder if it's the same person that pleaded and left the hospital without paying their full bills and stuff like that. So it's complex in that regard. So lack of resources in the hospitals. But hospital is a secondary thing. The primary issue is that women don't, a lot of us are anemic to start with, don't eat well, don't know what to do, don't do things that would prevent death, like even attending prenatal care classes. Some women I know in Nigeria those days, they will go to where they call prenatal class, they don't check their blood pressure. Blood pressure is one basic thing that if you can pick it up, you can save a life. The deaths from eclampsia and preeclampsia, which is a complication of high blood pressure in pregnancy, it could be dramatic. It's in fact, women in the US now, and even here, it's one of the higher killers because you hardly can do anything to stop it once it starts, but you can prevent it. Once a woman has hypertension and you pick it early, you can watch out for the danger signs. You can deliver the woman sooner than later and stuff like that. But those are things that some women just won't avail themselves of it. But there are other women who, they just can't get there. They live in isolated villages. There's no bridge connecting them to the main city where there's a hospital. They have to be delivered. A lot of places in the northern Nigeria, oh my goodness. It's not only the deaths, it's also the morbidity of vesico-vaginal fistula. Women will start passing urine through the vagina because they've been through labor for long and the tissues are necrotic. And these stories, I've seen them as medical students. As a medical student, I've seen them as a resident. I've seen them years after my graduation. I graduated in 1991. I became a specialist in 2000. And all these years, the figures are not changing. I asked one of my colleagues in Nigeria to send me the figures. She sent me that map. And I was almost crying. I'm like, are we not changing anything? Nothing is changing. We're still one of the worst in the world, unfortunately. So me reaching out is okay. If I can do blood banking, at least I take one part of the preventive ones. And that's
Okay.
why I said, okay, I'll do blood banking. I may not have to go to Nigeria to do that. I have colleagues in Nigeria where we are collaborating to make this happen. My classmates, the people from my university and all that were saying, yes, we can do this. We can make a difference with this. And this is what I'm spearheading right now, currently.
So you have a GoFundMe currently to support Nigerian women in particular. Do you want to tell us a little bit about that?
So the GoFundMe was created to help with this fight against maternal deaths with the blood banking. I mean, you know that blood banking is not a business. It's not just in terms of money to bring in materials and equipment and getting a house and all that. It's also about the ongoing blood donation, education around that, making logistics happen is a huge thing. And what we plan to do, our vision is to have the best blood banking network in Nigeria. That is the commitment that myself and my classmates had made. And I mean, I'm used to doing, oh, okay, I built this maternity home. We can start small. For blood banking, it doesn't happen that way. You need a large number of people to be aware. You need a large number of people. I mean, I would prefer to have 1,000 people giving me $1 each than $1,000 from one person. Of course, if somebody gives me 100,000, I'll take it. But I would really love a wide network awareness about the GoFundMe, and that's why we, went ahead with the GoFundMe to say, please let people be aware there's a problem. We're trying to solve the problem, and if they can come on board, that would be so great. And that's what the GoFundMe is. It's fighting maternal deaths in Nigeria with blood banks. Fighting maternal deaths in Nigeria with the blood banks. Florence Akindele, and I have my colleagues who currently are in Nigeria who probably right now don't want their names published. You will soon get to know them, but we are all working together to make this happen.
Okay, so pardon me, my non-medical brain cannot understand what blood banking has to do with maternal mortality. Could you please explain that?
So one of the leading causes of maternal deaths in Nigeria currently is women bleeding to death. They just deliver the baby, the bleeding, they need blood transfusion, and there's just no blood. And I've witnessed this again and again. There's just no blood in the bank. Sometimes there's blood, but it's incompatible. And so we then, we do all this kangaroo kind of, okay, let every member of their family come. And then one of my friends who runs a blood bank in Nigeria currently, she's also an obstetrician gynecologist and finished from Ife too. And she reached me through GoFundMe, which is another beautiful thing. I'd lost contact with her, but she saw it and she said, oh, I'm going to talk to you because I have a blood bank and these are the hassles. Somebody was stabbed and needed blood badly. So they brought 10 people to donate blood. Out of the 10, only one was eligible. They could only get one person. And this is after you would have to test the 10 before you say, oh, no, you cannot donate blood. And they found just one. So 1 unit of blood out of 10 people that were brought. These are the real challenges of blood banking and transfusing a woman who just had a baby and all she needs is blood. So a lot of women still die from that in Nigeria. So that's the link. I hope I've been able to link it.
Yes, ma'am, you've been able to explain because I didn't see it. I don't know. Maybe our audience too would appreciate that answer. So let's come back to North America. Let's come back to Canada now. Could you please help us explain why I feel there is an increase in immigrant women having more children than women born in North America? Is it true? Am I reading that correctly?
Yes, it is true. And I think it has to do also with the culture. Like I said, we had this initiative in St. Paul. They called it 100 Cups of Coffee. And I was invited to participate. And we were made to have conversations around moving the town forward and all that. And the coordinator, I don't know if I should be calling him coordinator. I'm sure he would not be happy with me with that word. What would I call him? The leader of the whole thing had mentioned the facts, and he was talking straight facts. Said, you know what? Developed countries, the women don't want to have babies. They don't want the inconvenience. They don't want the economic issues that come from raising a baby or a child. They would rather have a pet. And so many families are opting to have pets. But the immigrants are coming from the background of, I mean, even in my own culture, you get married, the next year everybody's asking you, where's the baby? Here, it doesn't matter. People can choose not to have babies even though they are married or they just got married. And you are not even supposed to be asking them, where's the baby? I mean, it's their choice. So it looks like more women out here are choosing not to have babies at all, or maybe have one. Whereas for immigrants who are just coming in, they're still coming with the culture of the fact that I think we, in my own tribe, we understand that the children are the ones that will be there to take over what you are doing to keep the community going. They're the ones that will be there to take care of you when you're older. They're the ones, that will help you around. So women are more inclined to have more babies coming from those kind of cultural backgrounds. But by the time we have our own children here, some of the culture here, is beginning to play in. And I see quite a number of immigrants, second generation immigrant children doing the same thing.
Dr. Akindele, I want to say a huge thank you for your time tonight and congratulations on Florence Maternity Home. We will help spread the word. How can people get in touch with you for either antenatal, postpartum care or obstetrics? Do I say postpartum or is postpartum depression?
Postpartum. It's okay. It's okay. So prenatal is during pregnancy, and then labor, and then postpartum is after delivery. So yes, I do have a website. It's florencewomenshealth.ca. We are revamping it. I believe by next week it should come out, and then the pictures of the maternity home would be included. And we can take things from there. There will be an email or a number to call. Already in my clinic, we do have a number to call, but most of the patients I take now are by referral. It's really been tough to keep up with the numbers. I wish I could be 100 of myself, but sometimes I just feel overwhelmed with the number of patients that I receive. So currently I receive gynae patients by referral only. And then for prenatal patients, I do receive patients who are pregnant, not by referral, but again, with the home, we're trying to see how we can work with midwives and make this a little bit different and see pregnant women in the home rather than in the clinic, so that we're just coming out to say, yes, we want to do things differently, want to try out this method of delivering services, considering both safety and comfort. So please, you can check our website.
Before I let you go, when I had my baby, about 2 weeks afterwards, a nurse came to check how I was doing. This was in the United Kingdom. Is this part of what you do? You go to people's homes? Does this service even exist here in Alberta? I wouldn't know.
It does. It does. So the public health services in Alberta Health Services does that, and they do it very faithfully. If they couldn't come out for any reason, whether weather or whatever, during COVID restrictions, they will reach out on phone to find out how mothers are doing. They will give advice and ask you to come to hospital if you need to. So yes, it does. It's still existing, but the women's home, we're not taking on going to people's home. It's people coming into our home and experiencing the home and the services that we provide there. So even though we provide postpartum services, it's in the home, not in the women's home. Because at the end of the day, what we want to achieve is that by the time a woman is going home, she's refreshed, she's rejuvenated, she's empowered to take on her normal life without much help from the medical system.
Dr. Akindele, thank you so very much for your time and congratulations on opening Florence Maternity Home. It is a big deal. Congratulations and happy International Women's Day.
Happy International Women's Day to you. Thank you so much. It's been a pleasure.
Yes, right. You can go rest now. Well
Thank
done.
you. I will.
Well done. All
Thank
right
you.
then. Good night, Ma.
Yeah.
Mhm.